to the next one. All right, can you see that okay?
Yes, thank you.
Excellent, thanks.
All right, for those who don't know me, I'm Jeremy Hirschler. I'm an addiction psychiatrist and the program director of the Addiction Psychiatry Fellowship at WVU. I'm going to talk about how to address complex cases of addiction today. We kind of covered this a year and a half ago in Project Echo, talking about case severity, and there's going to be a lot of similarities here, but different cases and some other ideas to think about related to complex cases. And then also I'm going to have some images from artificial intelligence. So this image here is what AI thinks complexity looks like. And so you'll see some images from Chatbox AI. All right, next slide, please. No financial disclosures. Next slide. All right, so we've been grappling with complex cases, ever since we got into this field, and it's like a knot of circumstances tightening around the patient situation. So, we really need to be able to address this complexity that happens with patients to provide good care of patients. And another thought about this is that if we're going to be good clinicians in the addictions field, we need to be able to treat cases that general practitioners are not going to be able to treat. And so for the most part, those are going to be complex cases. Next slide. All right, so the goal here is to arm ourselves with the skills that we can apply in our daily work to better care for those who are most vexing and challenging and need our support. Next slide. Now, if you think about this, so it may be that the failure to address complexity in all its fullness may be the primary driver of medical expense. Is there readmissions of patients who failed treatment and, just ongoing needs that need to be costly for patients. And also bad outcomes may be related to complexity not being addressed well. So just think about that while we're going through this presentation, and maybe we can have some discussion about that at the end. Next slide. All right, so I'm optimistic that we can make meaningful strides in the targets of complex cases. And I think what we're trying to do ultimately is engender trust. Can I be the most trusted name in this field to provide good care for complex cases? And this is an image from AI about what optimistic people look like. I'm not sure how they came up with that image, but that's what AI says. All right, next slide. All right, so here's my objectives. We're going to define addiction case complexity. We're going to describe how case complexity impacts outcome. We're going to describe the module strategy to address case complexity. And then we're going to describe how levels of care address case complexity and severity. And then we're going to go over some sample cases. We'll have some discussion points and some points about future directions. And then hopefully we'll have a nice discussion afterward. Next slide. All right, so Ralph Waldo Emerson once said, "Bad times have a scientific value. These are occasions a good learner would not miss." And so maybe the misfortune of other people in medical care are really opportunities for us to become experts, and knowledgeable about the field. And so even negative things are not entirely negative as we get good at understanding, the terrible things that happen to people. Next slide. And then along those lines, there's the African proverb, "Smooth seas don't make skilled sailors." And so if all of our cases are going to be easy, we're not going to become good sailors. So we need to kind of have difficult cases to strengthen our acumen. Next slide. All right, so have you guys heard of the Addiction Severity Index? This is a tool that's used. It's a general overview of the substance use problem and divides substance use disorders into 7 functional areas that are shown to be affected by substance use. And so these 7 areas are medical status, employment, drug use, alcohol use, legal status, family and social status, and psychiatric status. And my exposure to this goes all the way back to the VA Medical Center where I worked as a staff psychiatrist back in like 2000, so many years ago. I was working at the VA Medical Center. I worked there for 12 years, so in Baltimore, and they were using the Addiction Severity Index to assess kind of what's happening with patients with addictions. Next slide. And so McClellan in 1998 did research about this addiction severity index. And what he found is that patients who re-enter treatment programs often present with more severe addiction problems based on the ASI. And so they have problems or difficulties that are not addressed in previous treatment episodes. And so the reason that they're coming back is because their needs are not being met. And so we need to think about how can we meet the needs of patients so that their complexity doesn't result in ongoing needs for treatment and kind of treating them over and over again and maybe not meeting the needs that are kind of causing them to relapse and come back to treatment. Next slide. So Dave McDuff, who's he's the lead psychiatrist for the Orioles and the Colts. He trained me at the University of Maryland when I was in my fellowship. And he developed a concept of complex addictions and had, kind of had some different items that he identified. And that if you're interested in seeing his lecture, it's on video on YouTube. There's not really a big literature about complex addiction, but I've expanded his model into 12 items that make a case complex. And so the first item is multiple substances, and particularly upper-downer pairing. And the reason why upper-downer pairing is important is because if you think of Ed Consian's model of the self-medication hypothesis, he said people are using substances to correct some anger or depression or anxiety. And so people who are angry want a downer, or if they're anxious, they want a downer. And if they're depressed, they want an upper. And so there's like a self-medication element to what happens with substance use. Then you say, well, what's happening in upper downer pairing? Why would somebody want something that's both lifting them up and, kind of calming them down at the same time? And so those are really complex cases when you're dealing with that. And so we see like methamphetamine and opiates, or you can cocaine and alcohol. You see these upper downer pairings. And then risky routes of administration, so smoking and injecting. The reason why smoking and injecting are risky routes is because it's the speed of onset of action of a substance that makes it most habit forming. And so with smoking, the substance gets to the brain very quickly, from the lungs right up to the brain, and injecting through the venous system right into the brain. And so that's the most rapid kind of onset of action of a substance and makes it the most reinforcing. And so any kind of rapid onset is going to lead to a risky route of administration. And you even see this with benzodiazepines. Xanax is very lipophilic or fat soluble. And so it crosses into the blood-brain barrier very quickly. And so it's kind of a riskier benzodiazepine because it gets into the brain more quickly. And so any kind of drug that does this is going to make it more risky as far as addiction goes. And then serious medical problems, psychiatric comorbidity, cognitive impairment, those all make cases more complex. And then underemployment and low education make cases complex. Concurrent dealing and criminality make cases complex. Past out or ongoing trauma or loss, addiction during pregnancy, multiple concurrent addiction types like sex, substances, food, gambling, shopping, video gaming. So that'll make a case complex. Next slide. And then complex social factors. So like deep association with a marginalized group, like a gang affiliation or some other organization that someone's involved in that's going to make things more complex for them. And then cultures associated with high addiction stigma can make cases more complex, and family dysfunction and divorce. So all those social factors can make cases more complex. And then languishing, where a patient is stuck in kind of a dysfunctional state, and that can be in relationships or work or school or poverty or homelessness. So whenever someone kind of persists in this dysfunctional state, that can make a case more complex. And then early and late life addictions cases are more complex and kind of straightforward, average age people. Early addictions cases, if someone gets affected by addiction when they're young, the prognosis is worse. The trajectory of addiction is really damaging, and the younger someone's affected, the more difficult it is to treat it effectively. And then late life addictions is colored by cognitive impairment and medical problems, and so it's more complex in that way. And then the last concept is prominent individuals with a significantly developed career. And so these people, their impairments affect so many other people. And so they feel a lot of shame, possibly because of their addiction and the behaviors related to that. And so it can be very difficult to treat people who are prominent individuals because of the big impact they're having in society because of the substance use problem. Next slide. So there's not a lot of data about these complexity issues. It's not been researched to the degree that it should be, but we have lots of stuff about mental illness and addictions and about pregnancy. So here's some data. In 2014, 43.6 million Americans had some form of mental illness, and 20.2 million had a substance use disorder in the last year. And then of those, 11.3% had both an alcohol and illicit drug use disorder, and 7.9 million had a substance use disorder and a mental disorder. So you can see there's a lot of comorbidity that's going on. And so these complexities are pretty common. And then in 2012, nearly 66% of pregnant women use illicit drugs and 8.5% drank alcohol. So sadly, there's a lot of substance use going on in pregnancy that makes cases more complex. Next slide. So another thing to think about, and I introduced you guys to this concept of the general life review in my last talk a couple of weeks ago. But so this is kind of the areas or the domains of life, that there's 10 domains kind of in what someone's life is like. And so these domains are physical health and mental health and recreation and leisure and marriage and family and social life and environment and housing and transportation and education, work and finances and legal issues and appearance and spiritual life. And so all of these areas are potential areas for problems for people to have. And so complexity is often expressed by problems in many areas of life. And so you want to kind of think of the whole complete life situation of the patient and think, where do these problems lie and how can we meet the needs of these patients? Next slide. So these are complex evolving systems. So it's not like you take a picture of somebody in a certain situation and that explains their whole life, that people are evolving. And so often with problems that arise in the throes of addictions, it's kind of a spiral down, that they get more and more complex and involved and kind of ingrained in the patient's life. And so you can see why these complexities of addiction can be reasons that recovery can be so difficult. And this is an image from AI of somebody with a complex addiction. Next slide. So addiction treatment needs to tackle the disease in all its complexity to be successful. That's my argument. Next slide. All right, and so what this really means is staying on top of everything. So we get so focused in the medical model and focus on kind of the right medication for someone's diagnosis. And when it comes to complexity of patients that we're facing, you kind of have to think beyond just pharmacologic treatments or the diagnosis a patient has and think of their whole life situation. Next slide. All right, so how do we tackle this case complexity? Well, the way that I recommend doing it is by modularizing the work streams. And so what that means is that you're going to recognize patterns and apply the best evidence-based principles to the whole clinical situation. And so multidisciplinary teams are going to break the complex problems down into modules. And so once you do that, then modules will reveal talent gaps in the addiction program. So you look at this person's life and you think, what are the concerns they have? And how can we divide these into modules that people can address? And so what you really want to do is align the modules to the right people and have a clear and confident response to all the problems, the whole group of problems that patients face. And that's how you're going to get the best outcomes. Next slide. All right, so there's some interesting theory about kind of influencing multiple modules or domains in a patient's life. And this Rusk et al. Group in 2018 were looking at positive changes in multiple domains of life and found that if you just change a single module, it may fail to tip the system into a stable state and relapse can occur. And so what you want to do is have changes in multiple modules, and then you get a synergistic mutual reinforcement effect that helps to stabilize the system. And so if you have unchanged parts of the system, that can undermine the attempt to change, leading to relapse. And changes in one module can spill over into others. And so you get interactions between domains, and that can tip the system into greater stability. And the best changes are when they're a good fit for the individual, and then they promote useful changes in an upward spiral. Does that make sense to everybody? All right, so next slide. So here's kind of a diagram explaining what the thinking is here. And so if you have 5 domains of functioning and you change in B, they change one domain. So you've impacted one module. And then in C, it relapses because it hasn't stabilized the person's life. But in D, you have multi-domain intervention. And then in E, you get a nonlinear interaction where it tips into stability. And so in F, you get this stabilization where multiple modules have changed. So if you really want to impact the system, you have to kind of shift things in multiple modules. Next slide. All right, so another thing to think about are the ASAM levels of care. And so one thing that we have to do to address complexity and severity is think, how intensified does the treatment need to be? And so you want to select the appropriate level of care for the patient. And so the ASAM levels of care are early intervention, low intensity outpatient, intensive outpatient to partial hospitalization, inpatient rehab, medically managed inpatient. And so the idea here is that if the patient is failing the current level of care, intensify the treatment. And we've integrated this model into our co-clinic. So even in our co-clinic, our comprehensive opioid addiction treatment program, we have levels of care within that program. And so if a patient's failing a level of care, we can intensify the treatment. And if they're doing well, then you can make it less intense. And so that does a couple things. So if you intensify the treatment, the patient has to make more time commitment to the treatment, but they also get more health care. And so you're accomplishing 2 things. The patient's incentivized to do better because they don't want to spend all this time in treatment, but also they're getting more health care, so that's going to help them with the problems they're facing. Next slide. All right, so case examples. So these are not actual cases that we're going to go over. I've been practicing for 30 years. So these are composites based on all the clinical work that I've done, and good examples of the kinds of complex cases that you might face in practice. Next slide. All right, so case 1. A 40-year-old veteran of the Special Forces for 15 years with a long period of combat experience and difficulty adjusting to civilian life since his separation from the military has escalated in his alcohol use. He has had repeated episodes of unconscious emesis, which means vomiting, and aspiration, which means that the vomiting content is getting into his lungs, and now has fibrotic lung disease from drinking binges. He is unemployed but collects 100% service-connected disability benefits for complex PTSD. He's guarded about his combat experiences as his duties were classified. He lives with his wife of 18 years who's very distressed about his escalating alcohol use and his refractory response to treatment of PTSD. He takes Zoloft 200 milligrams a day and Prazosin 3 milligrams at bedtime, and Antabuse and Camprol. He is bored at home and has few friends. He does not go to AA meetings or other mutual support group meetings. He isolates, stops his antabuse, and drinks and is not involved with veteran organizations. He attends individual and group psychotherapy for PTSD and substance use, and he has outpatient psychiatric care. He feels hopeless about stopping drinking, but appreciates the persistence of his team of clinicians. He thinks that the things that he had to do in combat and the friends he lost haunt him with guilt, and he is numbing himself with alcohol and sabotaging himself in life because of this. All right, so why is this case complex, you guys? What do you think?
I'll keep an eye out for the chat for you, Dr. Hirschler.
Thank you. What makes this case complex? Any ideas? All right, yeah, so he's got co-occurring disorders. He's got a medical problem. He has fibrotic lung disease, and he has PTSD from his military service. So he's got psychiatric and medical issues going on that can make it complex. What else is happening?
Another chat in saying amount of moral injury. He feels personal responsibility and is punishing himself via alcohol consumption.
Yeah, so that's kind of the psychodynamics of what's happening with him. So I don't know if you guys think about kind of psychodynamic kind of aspects of substance use, but clearly there's a conflict there that's kind of driving some of this behavior. What else? I'll help you out. So he's bored at home, has few friends, so he's kind of socially isolated. He doesn't go to mutual support group meetings. And he's also languishing. So he's like stuck in this unpleasant situation, and there's no progress here. He's kind of been getting worse and worse rather than improving in any way, despite all the treatment that he's getting. So maybe he needs more aggressive treatment of his PTSD. And so what do you think about treatment of this guy? Well, we can go forward the slide to see what makes it complex. All right, so psychiatric comorbidity, medical comorbidity, social isolation, trauma, loss, languishing. It's a trauma and loss also make cases complex. All right, so how do we help this guy? What do we need to do? What do you think about his level of care, his ASAM level of care? I saw a thumb there, PJ. What do you think?
I think he may need to increase his level of care.
Yeah, so maybe he should go to rehab and get some time away from the substances and kind of get a chance to focus on some of these other issues, right? What else? What are his needs? What else can we help him with? What do we do about the social isolation? Go ahead, Abby. I'm sorry.
No, you're good. I didn't mean to cut you off. I apologize.
Go ahead.
Okay. If he's got this not too much motivation yet to change because of what he's experienced and kind of this personal responsibility, how would how would we kind of not talk him into, but how would we support him in a nudging sort of way to a higher level of care? Because we might know it's helpful, but if we kind of push him too hard, then he's going to disconnect completely from us, and he's already disconnected without any social network.
Yeah, so what I say about guilt with patients, some people have kind of a spiritual approach to that. I tend to avoid spiritual approaches unless patients have a background in that or have interest in it. And so what I might say to a patient is, it's who you become that matters most. Maybe these things happened and you feel responsible, but I'm interested in who you're becoming. That's where the rubber meets the road. And so let's see what we can do to help you become kind of the healthiest, strongest person that we can. And so what do we need to do to make that happen?
Thank you for that. I appreciate that.
Oh, you're welcome. Any other ideas? So maybe rehab, he needs psychiatric care. He's getting treatment of it, but I think they need to really work with this kind of unconscious guilt. It's not even unconscious, it's kind of conscious guilt that is driving this behavior and kind of make a resolve of that. And then we need to kind of get a social group for him, something that he would enjoy being part of.
Yeah, we got some chats and Richard was saying, would goal setting be appropriate for this patient? And then Katie chatted in saying, I would try to connect him with peer recovery support specialists that are also veterans.
Yeah, so that would be wonderful. So we got to kind of, so he needs to create a healthy social group, the people who are going to be a positive influence on him and people that he would feel connection to. So, right, veterans who are in recovery would be a great place to kind of meet people. And so we got to kind of open the door for that. And one of the things that they recommend in people going to AA meetings is have someone accompany them to an AA meeting, so that they don't go by themselves. And then maybe that would open the door for him to get involved in AA or, other mutual support groups if he was accompanied by somebody he had a relationship with. All right, interesting case, huh? All right, next slide. All right, case number 2, 35-year-old male with a history of methamphetamine injected and marijuana use who also reports a problem with a strange behavior. He collects his wife's feces in plastic bags and puts them in shoe boxes in the closet. He doesn't know why he does this, but finds it unavoidable. His wife is appalled and insisted he get help. He reports some male-on-male sexual abuse as a young teen by a family friend. He has a landscaping business, and after work nearly daily, he uses marijuana and methamphetamine with friends. His finances are tight as he is the primary source of drugs for his friends who are all part of a local motorcycle gang. He thinks he would have no friends at all if he didn't do this for them. His business is a success, but his team of workers all know about his out-of-control drug use. All right, so what makes this case complex? What do you guys think? Any volunteers? Financial stress, mental illness, yes. So he's got this compulsion to do an odd behavior. History of trauma, yep. Upper downer, yep. Lack of social support. He's associated with a gang, so he's in a complex social situation. It's hard to extricate yourself from a gang. He's kind of financing his gang friend substance use, and that's going to be tough as nails to get out of. That's a pretty aggressive group of people. Yeah, injecting meth is tough to treat. So this is the kind of substance use is a risky kind of administration of substances. So lots of reasons for complexity. All right, next slide. All right, so multiple addiction types, risky routes of administration, psychiatric comorbidity, complex social factors. All right, so how are we going to help this guy? What do you do for a compulsion? We psychiatrists here should have answers for that. Anybody? Dr. Zell, Dr. Husted? What do you do for this guy's odd compulsion that he collects his wife's feces? What's the pharmacologic answer for that?
Dr. Valtier said medication.
Yeah, so like an SSRI, right? Like Luvox or Prozac or Zoloft, maybe a tricyclic like clomipramine. So that's the kind of medicine that you would use for this kind of compulsive behavior. All right, then what other needs do we need to meet for this guy? What are we going to do about his gang affiliation?
Maybe see if he has any hobbies and try to connect him with like community groups that share those hobbies that aren't going to be negative social supports.
Perfect. Yeah. So he needs to social group reconstruction. He needs a new crowd. And so it doesn't have to necessarily be a recovery crowd. It could be volunteering. It could be, other interests that a class that he takes or other interests that he has, campaigning for a political figure, any kind of activity that would be healthier and be around people who are less likely to be using substances would be positive.
Kind of going off of that, Dr. Baltira also said new environment, but has financial risks.
Yeah.
Do we think perhaps any form of like couples therapy or anything like that would be helpful at some point in this to just make sure that the relationship between the husband and wife is kind of staying stable or regaining stability?
Yeah, so there are therapies. There's couples therapy and craft, which is a family therapy that kind of reinforces changes in the patient, and you don't reinforce things that are unhealthy, but if they're doing positive things, and you reward them, and you're kind of open about the reinforcement process. So something like that might really change this guy's behavior if there was some reinforcement going on of positive things from the family. Any other ideas? All right, next slide. All right, so case number 3, a 56-year-old woman drives a truck for a living. She was a competitive weightlifter when she was younger and had many musculoskeletal injuries related to her aggressive exercise routine. She has chronic knee and back pain and had several surgeries on her back and both knees. She used opiates off the street as well as anabolic steroids to augment her lifting performance. She is now on 12 milligrams of Suboxone for opioid use disorder and chronic pain. The long-range truck rides exacerbate her pain, and she uses fentanyl inhaled for pain and Adderall inhaled while driving to stay awake. She is a bit of a workaholic and rarely takes breaks for herself. Really, she can't stand not to work because she hates being bored with nothing to do at home. She thinks she may be depressed. When she has free time, she remodels her home. All right, so what makes this case complex?
The
Chronic
hobby
pain,
that she
yeah.
likes. Oh, I'm so sorry.
I just noticed that Katie's message there in the chat. Go ahead, Abby.
The hobby that she likes to do, like exactly what Katie said, the hobby that she likes to do is potentially not possible for her sometimes because of her chronic pain.
Yeah. So we need to, so she's on a moderate dose of Suboxone, which is obviously not doing the trick, and she's using fentanyl on top of it. So we need to think about kind of a more adequate dose of Suboxone to address her opiate cravings. What else?
Kevin said route of administration.
Yeah, so she's inhaling it. She's not smoking it. So inhalation kind of gets absorbed in the mucosa. It's not like getting into the lungs. It's a little bit different. But it could be risky, but it's less risky than injecting or smoking.
And then both Dr. Bixler and Baltiera said the risk of others driving and driving while using.
Yeah, so she's a danger. So this becomes kind of, you've got to wonder if this person, needs to be reported, or you need to warn her and say, look, this is inappropriate using these drugs while you're driving a truck on the road. And, is there an oversight of truck drivers to make sure they're appropriately healthy when they're driving and not under the influence of substances? I know they have that for pilots and that sort of thing. I wonder if they have that for truck drivers.
Yeah, the DOT usually manages that, the oversight of truck drivers.
So maybe just a warning would be a good incentive for her to kind of change what she's doing. Yeah, so she's a driven person, always working, Abby, and does it and uses stimulants to keep going and going and going. And she doesn't enjoy time alone too much. She gets bored. So the antidote to boredom is not entertainment to me. The antidote to boredom is goals. And so she needs goals in her life to make life more interesting so that she can strive for things that are productive and healthy. All right, next slide. All right, so multiple substances, medical comorbidity, chronic pain, and psychiatric comorbidity. So anything else about how to treat her? I think we covered it pretty well. What level of care does she need? But DOT does require some drug testing. Okay. So what level of care do you think would be appropriate for her? What do you think? So she's using fentanyl and Adderall, and can we treat her as an outpatient? No ideas. No one wants to take a risk.
I almost wonder if she would even benefit from a detox just to get a break from having so many things going on in her body and just to like sleep and just kind of get back to ground zero.
That's a pretty good argument. So yeah, it'd be nice to figure out what dose of Suboxone she really needs for her pain and to feel comfortable. So I call that a good hold. The medication holds you well. So when it's holding you well, you feel comfortable. You're not craving. You feel comfortable. And so it would be interesting to hear what dose of Suboxone holds her well. Vocational counseling, maybe a different career like that, Dr. Baltieri. I agree. A different career might be necessary for this patient. And then maybe create a social group for the patient that's positive and healthy, and so social group reconstruction, a healthy environment for her. Yeah. All right, next slide. All right, so discussion points. The ability to read the complexity and severity of difficult problems is an invaluable component of excellent care. And so what I'm recommending is a multifaceted approach to treatment. And so treat addiction as a complex disorder. So not just a medical problem with a diagnosis that you're going to tailor the pharmacology treatment to this. So a lot of these cases are pretty complex. And so you got to clarify the needs and then modularize the work streams and then choose the appropriate level of care. And then if the patient's failing the current level of care, intensify the treatment. And I think ideally what we want to do is engender trust. And so when you engender trust, you kind of set the energetic standard to which other people calibrate, both the patients and the providers that you work with. And so if you're engendering trust and patients can count on you, they feel that, and so does the whole staff. And so that's the best place you can be, the most trusted name that you can be. All right, next slide. All right, so future directions from crisis stabilization to strength and health. So this AI image is what flourishing looks like to artificial intelligence. All right, so what are the future directions? Well, we want to modularize the work streams and then create levels of care within each module. So if levels of care work in addictions, why don't we do that with work and with legal issues and all the different aspects of the patient's problems? Can we intensify the treatment if they're failing the level of care for the different modules? And so what I think, I was talking about core quality of life in my previous lecture. And so can you modularize these core elements of quality of life and have levels of care in those, to help patients have good quality of life? And so what we're doing by this is improving the overall health trajectory of patients. And so that's good. That's kind of giving them a critical part of their future. And so what you create by this is a complete solution for your trickiest patients. All right, next slide is my references. All right, so what do you guys think about this? This whole idea of complexity. Do you think this makes sense?
Yeah, I think it definitely does because I've said sometimes in the last few meetings is it's easy to, and again, not that addiction's ever easy, but the patient that comes to you on Suboxone that already has made the change, it's a very different patient. It's a patient that's homeless, that's struggling with pregnancy, and I think that last case of yours is really illustrative of that, because people whose drug use is tied to their work. So, I mean, this lady's, driving in pain, and her pain medicine's tied to that, and her stimulant use is tied to her job. Around here, we have jockeys that, have cocaine and opiate use disorder. And it's really hard to work with that because in their mind, they have to work. That's how they get through work. And so it's a big, big leap, to tackle that. It takes a lot. And so, yeah, but that model kind of works well.
Yeah, so I liked what you said about, sometimes you have to say, hey, this work life does not work for my life. I have to kind of find
Right.
work that's gonna work with who I am and, meet the needs that I have better so that I can thrive and function well.
Yeah, and to piggyback off that, what I find complex is for patients who, they are the only one in the household bringing in money to take care of the family. So sure, I would like them to go to inpatient treatment because I think that's what they need. But what happens to their bills when they're away, or what happens to their minimum wage job that doesn't save their job while they're away? I as a provider can make that, well, here's what I think is best for your care, but how do you in the reality, because you and I live in different realities, how are you going to make that happen? That's what I find really complex, is that it's easy for me to say, well, this is what I think you should do, but your situation may not warrant that being possible.
Yeah, that's a good point. So a lot of times patients need detox, and we think they need medically managed detox, but they have family at home or a dog at home or something that they
Yeah.
can't leave. And so what they really need is a very intense outpatient detox so this is kind of a gap in your treatment that you need to be able to meet the needs of the patients better.
Yes.
So it's a module that you don't maybe have the ability to meet that need. Do you think that the complexity is what the most costly aspect of addictions care is? That when we're getting expensive patient care and kind of readmissions to the hospital, it said, did McClellan's research make sense? That's what's going on and their needs aren't being met adequately, and so maybe we need a better system to figure out how do we meet these people's needs, and what do you prioritize? What are the needs that need to be met first? What do you think about all that?
I think
If you look at, go ahead.
so sorry, go ahead.
David, go ahead. I think she wants you to go.
Yeah. So I think a lot of it is, if you look at a lot of these patients that suffer from substance abuse and have multiple problems, they cross into the healthcare system multiple times, the ER, the orthopedist, they may get an infection, wound clinic. But unless you take care of all of that and their substance use problem, it's really hard. And even in mental health, people talk about dual diagnosis, but that means all kinds of different things. For some people, it's, psychiatric illness and developmental disability. For other people, it's, psychiatric illness and substance use. So even people that do dual diagnosis don't do the same dual diagnoses. And these patients, I really do think they're probably some of the most expensive for the healthcare system, because our healthcare system is made up by really specialists and partialists, and the inability to look at things holistically. And so that's why I think some of the programs like COAT try to do more holistic care, but that's what these patients need. So
Do you think learning to do that will make us skilled sailors?
I think some of us have already had to, I don't know if skilled, but survivalists, I think is more like it. I don't think I'm ever going to be skilled, but yeah, no, but it does. You look at things in a different way, so we're looking at, the pregnant woman who doesn't come in for prenatal care, who's on methamphetamine and fentanyl and homeless. Well, you can yell at her and get her a phone and, pick her up, but just take the care to her. You have to think really outside the box. How do you do that? And how do you, where do you need to meet the patients? and it's kind of motivational interviewing to the extreme and meeting the patients to the extreme, some of them. Even with our wound care for some of this patient population, we had somebody who they're like, oh yeah, send them to plastics in Morgantown. I'm like, we only find them every other week. Plastics is not a realistic, and then their addictions on top of that, and then their mental illness. And so I think, it's really kind of coming up with creative solutions. And some of it's almost just harm reduction, just keeping people engaged until they can engage themselves.
Or even to like, it begs the question, where are the environmental systems failing? Not even in the healthcare system, but outside of it. So like you had talked about like finances and things of that nature, like where, in the outside world that doesn't understand how healthcare or addiction works at all, where are the failures there that we can kind of broach into and help the patient with, because those have got to be overwhelming. And if the patients try to do that by themselves, on top of manage addiction care, and like Katie said, perhaps their job doesn't allow them to engage with the level of care that they may need, sometimes patients are not going to bring that up to you until it's potentially too late, because they think that you might not be able to help with that. So you kind of have to look at the whole picture as opposed to just like the medication part or just the part that's encompassed in the healthcare system.
Yeah. So we have some momentum here in Morgantown with Jobs and Hope and Reintegrate Appalachia, where these are people who are skilled at finding jobs for people with substance use disorders and legal problems. Get them, get them into a work situation that understands the kind of background and has already made agreements with the program to hire people like that. And so it's a big opportunity for people to get back into work life and kind of stabilize their, get that teeter totter moving over to the right.
Have about 2 more minutes left of the session. Thank you so much, Dr. Hirschler, for that awesome presentation, and it's great discussion from you all as well. So any other comments, questions? And Dr. Hirschler, if there are any other discussion points you wanted to ask the group, no rush at all. I just wanted to give that time reminder.
Do you guys agree that engendering trust is the ultimate goal of us as providers, is to, that the patients and the staff we work with can trust that we're going to provide care that's going to help them? Do you agree that's where we're kind of headed? That's the aim?
I'm seeing heads nod. Dr. Houston, I see you.
Yeah, I think the more that you can show them that you care about them in different ways by bringing up these things and addressing them, I think you're going to end up, engender the trust that they may not have with other people when maybe in the past, other specialties or other people are kind of scared to meet these complex needs. If you're willing to work with them through it, you can definitely get a lot more buy-in, and people are going to pay more attention to what you have to say and do.
Yeah, the other thing is that you recognize the pattern. So we're gonna see a lot of the same sort of things happen over and over again. And even though there's some weird things like that guy with that compulsion, the majority of our cases are going to be things that we sort of seen, and so we're going to have a lot of ideas about what to do about things we're familiar with. And so you get pattern recognition, and you can really slot them into the right person or the right intervention for this difficulty, this module they have.
Yeah, and both Dr. Valtera and Abby were talking about trust and repairing the distrust of the health system as well.
Yeah. There can be a lot of that. People who have addictions may be treated pretty negatively, by staff in the ER or anywhere really, that some people kind of have misconceptions about, how you should treat somebody who has an addictive disorder. And so that colors kind of their view of how how the healthcare system works. So we have to represent healthcare in a more positive light.
Absolutely. Any final comments or discussion points, Dr. Hirschler?
I can't think of anything. Important topic, though, I hope you guys realize.
Absolutely, absolutely. And as always, we'll have this on YouTube. We'll have a recap sent out. And if there are any further questions from the group or comments about the discussion we had today, you can email me, pass it along to Dr. Hirschler for you. Any final comments from the group? Questions before I wrap it up and then do announcements? Alrighty, thank you all so much. Only announcement that I have is the next session will be on September 25th, and Tony DiCiacchia will be presenting on marijuana treatment and reduction options. Thank you all so much. I hope you have a wonderful rest of your Monday and week, and we look forward to seeing you all next time. Take care, everyone.
Thank you, everybody.